We are live now, doctor.
Okay, thank you. Good evening, friends. My dear Dr. Grover and Dr. Venkatesh Krishnadas and the panelists, Dr. Santa, Swati, Devendra, Ganesh, Moideen, and my dear Secretary, Dr. Ram Gopal, Prasanna, and Sharmila, and other friends of TNOA and delegates. Very warm good evening to all of you. At the outset, on behalf of Tamil Nadu Ophthalmic Association, I extend a warm welcome to our friend, Dr. Davinder Grover from Glaucoma Associates of Texas. All of you know very well, Grover is a very busy glaucoma person in the US, and not only that, he is a very, very wonderful clinician and innovative surgeon, and has got lots of publications and other book chapters in the books. And not only that, he's a wonderful human being. We really cherish his friendship from Aravind, and also all ophthalmologists of Tamil Nadu and India, and of course all over the world. And I'm really thankful to you, Dr. Grover, in spite of your tight schedule, you have given this time. Definitely, your innovative technique of GATT is very much useful, and also many people from across the world have started doing it, and I think it's completely to change the surgical approach to the glaucoma, because you know, the guarded filtration procedure, the trabeculectomy, still it has got a role, but still some of the cases, early to moderate glaucoma, your GATT is a wonderful technique, and it's wonderful results, and also it's patient friendly. That's one of the important aspects about your GATT. And of course, about our association, Tamil Nadu Ophthalmic Association is one of the oldest association of ophthalmologists of our country, with the stalwarts in the field of ophthalmology. It was started about 70 years back. Now we are almost close to 4,000 members, one of the biggest association in our country, India. And of course, every year we are conducting different types of academic activities. And this year, we are actually doing wonderful work in the field of academics with various webinars and the debates and some of the journal clubs, and all these things so far cater to all the people in the ophthalmology, whether it's a resident or fellow or practicing ophthalmology or a particular specialist. In that way, every month we invite one of the stalwarts in the field of ophthalmology from international faculty in the field of cataract, cornea, pediatrics, and others. So this time I'm really happy to have you as a guest speaker for our TNOA webinar. Definitely this talk about GATT would be definitely useful for all of us, and also to refresh our knowledge, and also to improve our surgical technique, and to more about what is new in GATT. That's what we are eagerly waiting for today's talk. And with this, I just once again welcome you and other panelists and convener. And now I will request my dear Venkatesh to take over the.
Thank you, sir. Thank you, President. We welcome all the panelists and also the TNOA office bearers. I would like to briefly introduce my good friend, Dr. Davinder Grover. So he's in the Glaucoma Associate of Texas, and he specializes in complex glaucoma and cataract surgery, and also leads the clinical research team at the Glaucoma Associates of Texas. it's a very interesting story, how we got into ophthalmology and also into glaucoma. I'll just share some of my insights, which I've heard from Davinder Grover as an introduction to him. So way back when he was a medical student, I think Grover had an opportunity to visit south of India. I think it was Arvindai Hospital, Coimbatore, where he saw the staggering volume of cataract blindness and how the systems and the technique of small incision and how they were being taken care. I think somewhere motivated him to do ophthalmology. And getting back, there were a few mentors, like Susan Bressler was one of the person who motivated him to get into medical school. And then he was fortunate to meet two big faces in public health, David Friedman and Nathan Congdon, some of our good friends who have been here several times. And with their motivation, he landed into ophthalmology, and he did his ophthalmology residency. And then interestingly, the interests were between retina and glaucoma. And that is where I think Martin Goldberg, the then director of Johns Hopkins, played an important role in Davinder taking up glaucoma. He said, "You are an out-of-the-box thinker. I think glaucoma needs something to be thought out of the box. Retina is quite fast developing. I think you need to be in glaucoma." And that spark had something to do with Davinder getting into glaucoma, and fortunate that we have several of his innovations coming up. And following which his mentors like Fantas and few other colleagues made him think out of the box. And interestingly, the GATT idea came from a failed trabectome of his good friend and his colleague, Feldman. They were looking at the angle, and then they saw, can we do something in this failed trabectome? And that is how they put a suture into it, a 6-oprolin suture. It didn't work. And then they tried, why don't we try a catheter? And they landed up doing a catheter 360-degree trabeculotomy, and which soon became popularly known as the gonioscopic assisted transluminal trabeculotomy, and its history. Like any other innovations, it was also rejected to begin with. Every conference rejected his paper. Every journal rejected his publication. But he had to fight to prove that this is an amazing technique. And interestingly, now we are even doing low-cost options, and we are seeing the results of it, thanks to his perseverance again. And thank you, Davinder, for giving your time today. And I believe the story reads right. Now, if there is any modification in the story,
no, it's that's exactly right, Venkatesh. That's a 2 to 3 decades of my adventure, and you're absolutely right. It all started in the seed was planted in Coimbatore, and that was my first exposure to blindness, and the impact of blindness in other countries, and that was the seed that has now grown over the past couple of decades.
Several of these other innovations are also getting popular, especially the ab interno instrument for doing blood needling, and also the forceps for holding the muscles for inserting your tube shunts. So these are some of the things which people find it difficult, when they don't have good assistants and good systems around them to do these techniques. So that is where I think these innovations are so important. And this groundbreaking innovation, GATT, we are seeing the results now in India. Dr. Swati, Dr. Devendra, Mohiddin, Ganesh, everybody are now practicing it on a routine basis. I believe Mohiddin did half a dozen GATT last Saturday before he came to Pondy for a meeting. I mean, it was unbelievable, right? Half a dozen GATT continuously. It's interesting that it is possible, because it is so. Once you master it, I won't say it's a simple technique, but once you master it, it becomes so simple, like your cataract. So that is the way some of Davinder's innovations have changed the practice of glaucoma. And thanks to Martin Goldberg for motivating you to be a glaucoma surgeon and a retina surgeon, by which we benefited. And with this brief introduction, we request you to give the talk on GATT.
Excellent. Well, Venkatesh, thank you, my friend, for that very, very kind introduction, and RK, thank you also for the kind introduction. You guys have both kind of exemplified tremendous leadership in ophthalmology, being not just tremendous leaders, but also kind and compassionate physicians that we all strive to be. So it's such an honor to be here, and as Venkatesh mentioned, there's always a very special place in my heart for Coimbatore and my relationship and friendship with everybody here, because it's really the foundation of my story in glaucoma. And all the things that I've tried to come up with have hopefully tried to been safe, successful surgeries, but also cost-effective surgeries. A lot of the innovations in ophthalmology cost a lot of money, and that's not kind of my interest or my passion. So it's really nice to be here today. Thank you for having me, and I'm going to talk a little bit about GATT and just some updates on where we've been over the past 11, 12 years. The very first GATT was done here in Dallas in October of 2011. And as Venkatesh mentioned, anytime there's any kind of new thing, it takes a while for it to spread, and then it's also on us to show that it works. Not that it just looks interesting, but to look at the data and prove to ourselves as well as to others that this is a safe and effective way of treating glaucoma. These are my disclosures, none of which are really pertinent to today. I'm going to just briefly go over some an algorithm of my surgical approach to glaucoma, and discuss a little bit about circumferential trabeculotomy, give a brief introduction of GATT, and a brief data, not a lot of data on it, and then go straight into kind of some intraoperative tricks, talk about some of the instruments that I use, and then also take a step back, as Venkatesh mentioned. Everything when you look at a video looks easy, right? And we get humbled every day in the operating room. And I still remember the very first cataract surgery that I saw, and I said, "Oh wow, that looks easy. I can do that." And then the minute you get in the operating room and touch the eye, you realize how easy the surgeons make it look, but how difficult it can be. But with proper training, you can overcome that learning curve and perform the surgery. But it's hard. It's hard to learn. It's hard to learn every day. It's hard to learn, especially, when you're out of training. But it's necessary. And if we stop learning, we stop growing, and we stop being better physicians. So we'll talk just about some basic pearls of angle surgery, and then go into some management stuff. So in general. And this is what I tell my patients, I'm trying to open up their own drainage system. So we're not creating a new drain, I'm trying to do things that open up their own drain. And this idea of trabeculotomy, some people will say, well, GATT, how long has it been around? Do you know if it works? And it's a modification of a surgery that's been around for a very long time. It's just a less invasive version of that. So the analogy is an open appendectomy versus a laparoscopic appendectomy, and that's really, it's not a new surgery, it's a new approach to a surgery. And this has been around again since the 60s. And I love this picture because it's such a key portion, the number 3 down here, showing how the angle opens up after a circumferential trabeculotomy. And that's really still what anterior segment OCT shows today. And this is very classic for circumferential trabeculotomy, how the angle opens up only after circumferential trabeculotomy. You don't see this level of opening in other types of angle surgery. And I think that's connected to possible ways of success. So, why trabeculotomy? Well, we know from some landmark studies that the vast majority of the resistance to outflow in primary open-angle glaucoma is in the trabecular meshwork. Now, interestingly, in secondary glaucomas, it's actually probably higher because that's usually where the pathology is. And so we're seeing this evolution, and we're continuing to see an evolution. It doesn't stop with GATT. GATT is not the end of everything. GATT is just, again, a continuation in the evolution of glaucoma surgery and of angle surgery. And so I expect it over the next 5 to 10 years to get even better, safer, less invasive as we continue on this evolution. So what do? We call it GATT. It's an ab internal 360 trabeculotomy, gonioscopy assisted transluminal trabeculotomy. And this is an artist that I hired to highlight the key portions of GATT, making a small goniotomy and then passing the suture or catheter around 360 degrees. And this is some nice still pictures using a 5-0 proline suture with a blunted tip. And this is just a nice instructional video on GATT, highlighting some key steps and some do's and don'ts. So, you want to make the smallest blunt possible. You need to make a small mushroom tip. And you're going to see, I'm going to purposely make it too big. And that's way too big. So I'm going to cut it. Thankfully, proline is not expensive, so you can trim it and do it again. You want to wait for it to make the slightest change. And that's what you want it to look like. The smallest blunt you can make is what you want it to do. And then before I start, I estimate the circumference of Schlemm's canal. And then I'll make a kink in my suture. Okay. And that kink tells me I should see that kink. If I see that kink and I don't see the tip of my suture, I've gone too far, or the suture has gone somewhere else. And so I need to look back and think. So, this is a right eye. So I'm sitting temporal. I'm making a temporal incision and an infranasal incision angled towards the nasal angle. The patient is phakic, and this is an isolated GATT. So I'm giving some myostat and then some Helon GV. And what I just did right there is so key. I'm putting on a little bit of the Helon on top of the cornea. That helps as helps the gonioprism stay connected and helps your view. And then before I tilt the scope and tilt the head, I put my suture in. I shimmy my MVR, and this can be done with a 23 gauge needle, a 25 gauge needle. It doesn't have to be an MVR. And then I like to make a couple clock hours of a goniotomy, just to give myself a good place to land. And then that other maneuver is key. I push back on the lower lip of the trabecular meshwork to see the white strip of the canal. And you want to transition and go as tangential as possible to the back wall. And you're going to see I'm moving my gonioprism a little bit, right? So it's a dynamic process. And the place you're most likely to go in the suprachoroidal space is that first 90 degrees. And so once you get past that first 90, that's a good sign. And then as you're going along, you should feel more resistance. So here you see that kink, and then you see my suture. So I know that my suture hasn't deviated because I see the kink and I can see my distal tip. I go over the suture and then stay there and then pull tension on the proximal tip. Now I'm going to wash out with just balanced salt solution and look at the vessels around. You're going to see them blanch. And that we've termed the episclerovenous fluid wave. And that's really a nice indication that the patient has an intact outflow pathway. And there have been some studies that we've done and others have repeated, it's that nice blanching to show that the more of the wave you see as you're inflating the eye and balanced salt solution is going into the collector channels, the more of the wave you see, the higher the chance of success of the surgery. And I don't want to spend too much time on the data, but it's important to, whenever you come up with something, to show the data, because it can always look good on videos, and you can see my best video, but you don't see the complications and you don't see the long-term outcomes. So it's important whenever you're showing this to show data. And this is our 2-year data showing that patients have a sustained and significant drop in pressure and a sustained and significant decrease in medication over the 24-month period. And again, trabeculotomy has been around for a long time. So we know trabeculotomy works, and our outcomes are just as good, if not probably a little better than the traditional ways of doing trabeculotomy. So last night, I just did a quick overview. And actually, if you look to PubMed, and you just search for GATT, there are 88 publications on GATT. So, it's really just spread more and more. And that's always nice to see, right? Whenever something comes out, it's one thing if our group publishes on it, but to see that it's being replicated and published more and more is really, it's really nice to see and provides validation of the surgery. So let's talk about some tricks. I'm going to talk about a couple of the tricks of what happens in the angle. Here's an example of some bleeding. So I'm going to kind of forward this a little bit. This is key. I'm going to go as tangential as possible to the back wall of the canal. And again, you want to just take some slow bites and watch my gonioprism throughout all these videos. You're going to see me move my gonioprism with everything, because I want to know that the suture passes the first 90 degrees. And then I'm going to forward this a little bit. And this is a combination with cataract surgery. So I do the GATT first. And so here I do the GATT, and then I retrieve it, and then I start to get some bleeding. And you know, on your first GATT, you might want to do this as an isolated surgery, because this can make your cataract surgery a little bit more challenging. And so I typically do the GATT temporal, and then I move up to the top, but you start to see some bleeding, right? And it keeps coming. So what do you do? So first, with everything, you need to keep the anterior chamber formed. So the minute you see that kind of bleeding, pressurize the anterior chamber. And then I also, and I'll show this later, I'll put the patient more in reverse Trendelenburg to really minimize episclerovenous pressure. And then you can move forward with the cataract surgery. But don't let that blood keep coming, otherwise it's going to mess up your view. Pressurize the eye, and sometimes just holding it there and waiting will help tamponade some of the bleeding. Here's an example of the suture coming out of the canal. Again, I'll show the back, pressing on the back wall, and I'll show this a couple of times. It's repetitive, but this is kind of the key portion of just getting in. So I want you to see multiple examples of going tangential, being gentle, not poking through the back wall, and really making sure you turn around that first 90 degrees. And then watch, you're going to see me just moving and moving and moving. And you're after 180 degrees, you should start to have some resistance. If you don't have resistance, you've got to pause and think about what's happening. And sometimes the suture can pop out of the canal, and you don't know it, right? And so here I'm not getting the level of resistance that I expect. And in this case, thankfully, the suture, it popped out of the canal, but it stayed in the angle. And so you always have to kind of be watching of where you are, what are you doing, where's the suture. And so you can see it stayed out of the canal. It popped out of the canal. Sometimes it pops out about 180 degrees. So what I'll do is I'll just treat the otomy. So it popped out probably right about here. So you can see it comes out. So then I've just treated 180 degrees. So what do? Well, then I'll make a superior nasal incision and put my suture, and now I'm going to go clockwise. And you can usually still treat 180 degrees without a problem. And what's nice is once you open up 180, there's less resistance in the canal. So usually the other 180 is key, is easier. So I'll go through my same goniotomy site and get back into the canal, but go the opposite way. And again, I need to know, I know I need to just treat that 180 degrees, but you're just watching and thinking the whole time. And patience, gentle. This is all microsurgery. It doesn't need aggressive moves, doesn't need a lot of strong movements. It's all very, very subtle micro movements. So you can see this resistance that I'm getting. That's actually a good sign, you know, that I'm still in the canal. But with persistence and patience, you just keep going, slow bites, slow bites. There's probably a little constricted area, subincisional, that makes it hard. But with patience and slow, gentle bites, you can get through that. And then you start to see the suture come around. And again, even though the angle is open, it stays in the canal. And then when you come out, you can see that I've already treated 180. You're going to see the other 180 that I've treated. So again, I'm going to hold it right there in the middle, come off the eye. And I'm going to treat the remaining 180. And you can kind of see that, you'll see how much has already been treated and how much needs to be treated. So now I can say with confidence that I've treated 360 degrees. Now sometimes it can come out of the canal and it actually gets embedded in the iris, or actually, in this case, it went posterior to the iris. And this is, again, important for you to always watch and think, because if you're not careful, it can cause damage and trauma to the iris and an iridodialysis. So so I'm going around, and again, I'm going around and I'm not getting the resistance. And then you see my kink. I see my kink, but I don't see the suture. And so I pause and I look back and I see that the iris is indented in. So something's going on. So you need to pause and think. So then I pull back on the suture and you can see that the iris is goes back to normal. So my suture had popped out of the canal and has gone posterior to the iris. So then I come back out and then you can still just, I call it walking the dog. You can kind of treat a little bit of the angle, but then go the opposite direction. And again, whenever you're doing this, you got to always think and watch to make sure you know where your distal tip is. Now with the catheter, you don't have that problem because you can see the blinking light. But with the suture, you need to be much more aware of it. And what's interesting is, all the people that I've taught GATT to, oftentimes they actually find the suture is easier because the suture is less likely to kink. It's a little bit stronger, and it's just easier to manipulate. So the blinking light is helpful, but oftentimes the suture is a little bit, I think, easier to do. So again, I'm going the opposite way. I'm passing it, and I'm just looking. I'm looking at the iris. I'm looking for my kink, and I'm looking for the distal tip. And thankfully, it's the angle, the suture is right in the angle and staying in the angle. And then I can go ahead and treat. And now, again, I treated 360 degrees. So here's another example of what happens when the suture stops. And again, you always have to kind of just be dynamic and watch what's happening. So sometimes it just takes a little bit of extra energy and patience. And then sometimes it just stops. And that's what's nice about the suture, is that when it stops, it actually stays embedded in the canal. And then you can just pull on it and treat 180 and then go the opposite way. All right. So again, I'm passing it, and it's not going at all. And I'll keep trying, but eventually you realize it's just not moving. And this is when you're at risk of causing a iridodialysis or a cyclodialysis if you're not careful. So if it's not moving and you're really getting that constricture, sometimes you just got to call it and say, okay, hey, look, I've done 180. So you can just pull on it and it stays in the canal, and there, boom, I've treated 180 degrees, right? It stays in the canal. Now the catheter will snake back out and it won't treat. And so then what I do is I do exactly what I showed before. I come back around. You can see my suture is kinked. I go the opposite direction. And thankfully, because I've opened up 180 degrees, the remaining 180 is a little bit easier to treat. And there's less resistance. So then I'm able to go. And what's nice is that for some reason, the suture usually still stays in the canal. So you can see my kink, and then you can see the distal tip of the suture. And so then you can treat the remaining 180. The key thing with all this is maintaining your view. And this is what's nice about the view is I know when Swati was here with me way back when, she's like, well, how come I've seen other people do GATT, and how come your view is different than their view? And I'm very intentional about my view and why I maintain a chamber and why I have a good view. So this is just if you want to take a screenshot, this is the kind of the key things that I use for suture GATT or catheter GATT. And then kind of what I talked about. So pass the suture. I always pass the suture so that when you go around, the most common spot or to stop is about 180 degrees to 270 degrees. And so if it stops, I want it to stop at the 6 o'clock position. That way I can move to the head of the bed and then retrieve it if I need to. So that means in a right eye, I'll go counterclockwise so that 270 degrees is 6 o'clock. And in a left eye, I'll go clockwise so that 270 degrees is at 6 o'clock. Depending on the wave and how much blood reflux, I will leave some helon in the eye. Early on, don't leave too much helon because you can be at risk of a pressure spike. So, but if you leave a little bit of helon, maybe 10%, that'll minimize the risk of a hyphema and early hypotony. As I mentioned, the cost implications of the suture GATT are tremendous. It's less likely to kink, and a lot of the early surgeons that I've worked with find that the suture is easier. Even in the US, people are using the suture with more preference than the catheter. Except in if you have the option for the catheter, when I do babies, or tiny, tiny babies, or even people that are 1 and 2 and 3 years old, their canal is more likely to be irregular. So I use the catheter only in the babies now. My colleague in Turkey, she does a lot of pediatric GATT, and she does a suture without a problem. But it's just, again, you have to be aware that the canal is more likely to be irregular. So when do I use GATT in the US? So I use GATT in mild to moderate glaucoma with or without cataract surgery, almost all stages of secondary glaucoma. And then I don't do it in like ocular hypertensive. These patients need to have real disease. Now there's also, the Canada groups in Canada are doing what's called a hemi-GATT, where you open up 180 degrees, which I think is also a very great way to do it. So you can kind of modulate. If you don't need that tremendous pressure lowering, you can consider opening up only half the canal. Again, hemi-GATT is just a continuation of the evolution of GATT and how other people around the world are doing it. The best patients, again, are this moderate to mild glaucoma, all stages of pseudoexfoliation, steroid-induced glaucoma. I call it this Avastin-induced glaucoma, patients that are getting multiple injections of anti-VEGF treatment. They end up getting some clogging of their meshwork, and they do really well. Controlled non-granulomatous uveitis, traumatic eyes, once the eyes have settled down, all stages of primary congenital glaucoma and juvenile open-angle glaucoma. And this is what I learned when I was in India, because in the US, patients are usually on drops for 20 years, 10, 20 years before they have any surgery. And that chronic use of drops, I think, is very harmful to the eye and causes scar tissue. And so in the US, we've kind of did a proxy for, if they have advanced stage of glaucoma, they don't do as well with GATT. And so the first GATT patients I did in India, in Tamil Nadu, were in patients with advanced glaucoma. But those patients, as you all know better than me, they haven't been abused by drops for 10 years, 20 years. They're more virgin eyes, and their eyes were just pristine. The conjunctiva was healthy, the meshwork was healthy. They behave very differently than eyes that I see in the US that have been abused by drops for 20 years. So those eyes have do really, really well. And that's what makes me very exciting about the use of GATT or other angle surgeries in India. I don't do this in very advanced stages where their eyes have been abused by drops. If patients need to be on, have very, very low pressures on no meds, you may want to still consider more traditional surgeries. If they can't be taken off blood thinners, or they can't limit their activity, or if they have an unstable lens, when you inflate the anterior chamber, it can dislocate a lens if you're not careful. Or if they have broad PAS, that'll cause a lot of inflammation and scarring. So I don't do it in those patients. This is typically what my post-operative course. I'm very aggressive with my steroid regimen. Once the eye is quiet, I back off on the steroids. There's more and more people that are suggesting the use of topical NSAIDs, which I think is also very helpful for controlling inflammation. They will get a steroid response sometimes, and when they do, the best medication to do is pilocarpine. It works tremendous in steroid-induced glaucoma, and so that's the first drop I add back. And I treat their medication. I treat their pressure with glaucoma drops as long as they're on steroids. I don't taper the steroids until the inflammation is gone. Once the inflammation is gone, then I taper the steroids. Then I will back off on their glaucoma drops as needed. And then, if they have a significant hyphema in the first week or two, that kind of inflammation can lead to scarring. So I have a low threshold for washing them out. And then, I just slowly, if the pressure is not ideal, I don't stop the steroids. I slowly increase their drops. Once the eye's quiet, I taper the steroids. Then I pull back on the glaucoma drops. So this is just some keys for just the surgeons that haven't really done a lot of angle surgery. They just want to get into it. The key thing is just clinic gonioscopy. I perform gonioscopy in clinic probably 30 to 40 times a day. And unless you're doing gonioscopy like that, you will not understand normal anatomy, normal variations, or abnormal anatomy. So you have to just, I have a gonio prism in every one of my exam lanes, and I do it any chance I get. I perform in clinical gonioscopy. And then I suggest doing intraoperative gonioscopy. You know, once you're doing cataract surgery and the lens is in the bag, before you wash out your viscoelastic, that's kind of the safest point of surgery, right? That's when you kind of start doing your victory dance. At that moment, once things are safe, just play with this. Tilt the patient's head away from you, tilt the scope towards you, and just look. Don't do anything, just look. And do that for 10 times. And then once you do that, then just put your second instrument in the eye and just kind of see what it feels like, that tactile interaction that I'm talking about, of using your gonio prism and the second instrument, and just seeing what it looks like to be in the angle and have that spatial perception. Once you do that, then you can kind of start escalating things to a little bit more involved. You can do things like goniotomies. You can do a hemi-GATT to kind of get a sense of what it's like. And once you do that, then you're ready for, you know, the manipulation it requires to do a GATT. So make it a stepwise progression. So if you watch the videos, you know, again, when I watch cataract surgeons, when I watched Venkatesh do cataract surgery, he just makes it look so easy. But there's all these subtle tips. So this is, you know, you see this picture right here. What are the subtle tips? One, there's a water stain on the gonio prism. That's not good, right? That's going to mess up your view. So make sure you clean that off. Two, there's helon on the eye, and then there's helon on my gonio prism. So my surgical assistant knows not to hand me a gonio prism without helon on the bottom of it. And then I will always put helon on the eye. That helps maintain the seal of the gonio prism in the cornea and maximizes your view. Huge, huge, huge. When you're making your corneal incision, try not to hit a blood vessel. That blood will come in between the interface of the gonio prism and the cornea and mess up your view. You see, what's the difference between these two views? This difference is maintaining your anterior chamber. And this is true for every anterior segment surgery you do, be it a lens surgery, sutured lens, cataract surgery, you name it. The best way to minimize any complication with anterior segment surgery is to maintain your chamber. If you don't have a chamber, you're at risk of a complication, and angle surgery is no different. So maintaining your chamber, if you can't see, you can't do the surgery. So take your time, form the eye, and if you start to see kind of blood reflex, put the patient in more reverse Trendelenburg. This is how I do all my surgeries. Every surgery I do, be it a tube, be it a trab, be it a Zen, be it cataract surgery, be it anything, a sutured lens, all my patients are always in reverse Trendelenburg. That minimizes episcleral venous pressure, and it minimizes your risk of a choroidal hemorrhage on the table. It minimizes positive pressure. It really just keeps, I think it's just absolutely safer for all anterior segment surgery, even probably retina surgery too. And then posture, right? So, you know, when you're stressed out, when I'm stressed in the operating room, my shoulders go up, and I start doing this. You need to pause and take a step back, make sure that your shoulders are down, make sure you're sitting straight. You can see my hand positioning, rest your hands on the patient, sit up straight, be comfortable, so that the scope is tilted towards me, the patient away from you. And that kind of positioning is so key to maintain, to be comfortable. Now, what's the difference between these views? So there's something called an above view and an en face view. So if you look at this picture right here at the bottom right, if you're kind of looking above, and it's very subtle, because even that view on the left, you can see the angle, but you're looking at it from up top. And if you're coming down like that, you're actually at much higher risk. You're taking that approach, you're much higher risk of creating a dialysis cleft. If you're looking at it when it's across from you, you're going straight ahead. The thing behind it is the canal, not the ciliary body. So you really need to make sure you have that broad view. And you need to kind of play with that. and look at it, because it can deceive you. And if you're looking above, you're going to go down and cause a dialysis cleft. If you're looking at it from head on, it's much safer, and it's much easier. And here's an example. This is, I mentioned you can transition to GATT. One of the transitions to GATT, and Dr. Davinder has some great experience with this, is the Tenedo goniotomy, right? So this is from a professor out of Japan, Masaki Tenedo, that's kind of created this reusable goniotomy that it's kind of easier to use than GATT. It's still cost effective, and I think the outcomes are probably not as good when you're opening up a small amount of it, but they're still pretty good. So this is all about an evolution of GATT, an evolution of angle surgery, and doing what you need to do. So not everybody needs a GATT. And actually what he did was he's published on a lot where he starts temporal, treats 180, and then he goes on the other side of the bed, sits, reaches across the nose, and treats temporal. So he's able to treat 360. But I think the nasal bridge in patients of Japanese descent is a little bit easier to reach across the eye than in other ethnic backgrounds. But let's look at this Tenedo goniotomy, and because you can get a nice view of that. So and again, there's a straight and a left and a right. Again, you see there's there's viscoelastic on my gonio prism, and I'm just going to treat 90 degrees each way, and we're actually working, and I will be doing this more, I think, at Aravind with Dr. Vendra on a modification of this this instrument that I think is even better, that I'll be able to have some data on very soon. But you can see that you're able to open up the canal. You see the back wall of Schlemm's canal, and I'm treating 90, and then I'm going to go the opposite way and treat the other 90, and basically treating 180 degrees with an instrument that doesn't require a lot more manipulation, but it's still reusable, and it's still relatively easy to do. So I think this, if you're starting to play with angle surgery, this might be a very good thing to start with. And you can see, again, I'm moving my gonio prism left and right to get a better view. And so this is to the right of the screen is nasal. So that's where I opened up, and you're going to be able to see that wave. So you can see a nice episcleral venous fluid wave on the temporal side. And this is another example of the Tenedo. And yeah, again, watch my gonio prism. I'm moving it as well. And again, a nice shelf you can see, but I'm moving that gonio prism to maximize my view. And the more, you don't need to go that far out temporal, or sorry, to the extremes. You can really just treat the central part. But the more adventurous you get, the more you can move your gonio prism to open up more of the angle. And you see a little bit of blood reflex, but you see that nice trabecular shelf. And again, look at that use of the gonio prism to optimize my view. That's the kind of comfort you need to get. And again, this is now this is a right eye. So you're seeing that nice blanching over in the nasal quadrant. Again, it's not 360 like with GATT, but it's a small nasal wave. So, when you're trying something new in the operating room, I always, you got to plan ahead and do as much as you can. So, and there's no room for pride when it comes to the operating room. And I always I'll talk it through with one of my colleagues that I trust. And then when I first try something, I have them come to the operating room with me. So they're watching as I'm in the hot seat, and they're thinking and helping me be better. Practice in the wet lab, draw it out before I do any surgery that's new. The night before, I sit down and I draw out every step. And then, again, I always have an open door policy in my operating room. Anybody is welcome to come. So in conclusion, we talked about GATT, how it was a novel, safe, minimally invasive surgery. 2-year data is pretty, it shows significant and sustained pressure decrease and medication decrease. There's definitely a learning curve. You need to make sure you have a good view. And we talked about strategies for making that good view. Maintain that patient in reverse Trendelenburg and be gentle. This is microsurgery. This is not orthopedic surgery. So everything we do requires micro movements, not harsh, heavy hands. The suture GATT is without question a tremendously cost-effective way of treating glaucoma. And I think, as you're seeing this explosion of MIGS, part of it's because of the cost and how much money companies are making. But I think we need to start thinking about cost-effective methods of treating MIGS, especially in health systems like India, where you're much more aware of the cost. And in the US, we're going to start being held accountable for that too. So this is a map of GATT worldwide. As far as I know, it's being done now in over 30 countries, and I hope that the waves continue to grow and more people do. And it's without question, this is from one of my colleagues, Bryce Ford. He did a cost evaluation analysis of cost-effective MIGS or cost-effective glaucoma surgery, showing that GATT is without question one of the most cost-effective surgeries out there per millimeter mercury lowering. We teach a course every year at the Academy. Like I said, I have an open door policy. Anytime, if any of you find yourself in Texas or in Dallas, please let me know, and you're always welcome to come to my operating room. And this is, RK mentioned what's new. This is something that is just coming out very soon, and it's a 26-chapter book that Dr. Feldman and I put together from GATT surgeons from around the world. And Dr. Swati wrote the chapter on GATT in India. And it's really a brain trust, a collaboration of GATT surgeons and GATT masters from around the world that have come together to teach the world about GATT. And so this is put on through our foundation, and all the proceeds from selling this book will go to the foundation to provide this book for free to low-cost regions. And this will be coming out probably in a couple weeks. Actually, I think we're trying to launch it at the American Glaucoma Society. So we're very, very excited about that and hope that it will continue. Again, GATT is not the end. It's just a continuation of the evolution of angle surgery. And this hopefully will help other great minds around the world continue in that evolution to make GATT even better, or to come up with something better than GATT. So thank you to the Tamil Nadu Ophthalmic Association and Mr. President, Dr. RK. Thank you for organizing this, and Dr. Krishnadas, thank you for being there as well. And Venkatesh, appreciate you monitoring this, and also all the panelists are my dear friends that I've known for a long time. So it's so nice to see everybody, and hope one day I can come out there soon and we can do this together in person.
Thank you, Davinder. I mean, it's always a pleasure listening to you. And so whenever you keep talking about the tips and tricks, you feel how passionately you've developed this and how you want people to kind of have a walkthrough when they learn this. It's so important. Some of these are very subtle tips, especially when you kept saying, move your gonio lens, this side, that side, the first 90 degrees. How to keep the reverse Trendelenburg is so important to avoid the bleeding. When people start doing it, they understand how important some of these tips are. Even the tint is so important. You know exactly when that suture is 360 degree. So I think like your 360 degree trabeculotomy, I'm sure the GATT is already reaching 360 degree in the globe. Even recently to my visit to Ghana, I was showing, and then people got excited, and then they said some of the surgeons have already started doing angle and they are also interested. So through your Cure Glaucoma Foundation, I'm sure you're taking some of the low-cost options, because developing world and also in Africa, where you see very advanced open angle glaucomas, this is going to be a solution, because glaucoma is a surgical disease. And in countries where people cannot afford medications, where you're going to diagnose glaucoma very late in their stages, it is going to be surgery. When an eye is virgin, if you're going to do a GATT, I'm sure you can achieve the best results than what the results you have been showing in some of the American eyes, where they have anti-glaucoma medications, 3, 4 for several years, where there's a lot of compromise to the angle, to the outflow channels. So that is where I'm sure we are going to find better results. I'm sure the colleagues here are working, and in Africa, maybe in a couple of years down the line, we can see some of the work being done, and also we'll see some good results. So I'll open it for the panel to start the discussion before I get some questions through our Numerotech team. Any first-hand questions from the panelists who are already practicing? I believe Madam Shanta has also joined from Shankar Netralaya. Thank you, Madam, for joining the session as a panelist, and we can start with you.
Thank you. I am not performing GATT at the moment because, us being a tertiary care center, we get very advanced glaucomas or repeat surgeries. But we have started using the KDB goniotomy and eye stent for a few cases. My questions regarding GATT are the first, since you're treating 360 degrees in adults, I have no reservations about using it in children, but in adults, if there is any future prospect of innovations in improving the drainage through the trabecular meshwork, either using drugs or any other modality, wouldn't this 360-degree treatment hinder any progress?
Yeah, no, Dr. Shanta, that's a great question, and it's an important thing to think about, right? So if you talk to, there's a researcher, probably the person that knows the most about the angle and trabecular meshwork and the behavior of the trabecular meshwork. His name is Murray Johnstone. He's really pioneered the understanding of kind of it's not just the meshwork and the canal, but actually there's a pump mechanism, and there's valves, and there's all these structures in the canal that actually help the meshwork function, and there's all these microstructures in the canal that when you do a GATT, when you're going through it, you do actually destroy I think you destroy those mechanisms. Now, if you ask him, well, what we do is this bad for the eye? He typically will tell you, and what he's told me is that at the stages of glaucoma that need surgery, it's usually those mechanisms are not intact anymore. Right. And so you're likely not, you might be destroying tissue, but it's probably non-functional tissue. But, we're doing things today we thought were impossible, 5 years ago, and hopefully in 5 or 10 years, we will have better options to possibly treat, more of an intact canal. And so that's sometimes the argument for maybe considering like a hemi-GATT or treating half the canal. But what's interesting is also, as you know, the canal is not equal. 360 degrees is not equal everywhere around. Most of the outflow pathway is in the nasal angle. But in theory, if that's a concern, then what you could do is treat 180 and then leave the temporal angle for any future potential interventions at that time. But usually these patients that in our hands that have GATT, if I'm doing GATT, I want the biggest pressure lowering possible because they're losing vision. But it is important for us to always think about that, and what if the structures that we're doing or the surgeries that we're doing are leading to potentially more harm. And we haven't seen that, but it is, that is a thought that is important to kind of try to preserve some normal tissue, or if it is normal.
My second question is there any histological comparison of the effect of the eye track versus the suture? Is there a possibility that the suture is a little more invasive than the eye track catheter?
Yeah, no, and I've done patients where I don't have any histology to prove it because we haven't done it or any postmortem sections. But I had patients where in one eye I've done a suture GATT, and in another eye I've done a catheter GATT. And the anatomy is about the same, postoperative anatomy, and the outcomes are about the same. Now, there are some people that advocate for doing viscodilation as you're going around, and they think that might help. In theory, that might help prevent a little bit of blood reflux, but we have not seen outcomes to be significantly different when doing it with the suture versus the catheter. So no, I mean, the cost is significantly different, but the outcomes would not seem to be different.
Thank you so much. It was a wonderful talk. It was a pleasure to listen to it.
My pleasure. Thank you.
Yes, Mohidin.
And I think that the key is to place or gonadal incision. So just explain where exactly you make it, because that's the way I feel a very important, crucial step in especially in GATT. I think the visibility of the angle and the tilt of the microscope and gonadal incision going to be very crucial. You just explain to the people exactly where you make an incision.
Yes, it's what's funny is the very first GATT that was ever done, I did again with Dr. Feldman in October of 2011. And we sat down and planned out the surgery the day before and said, okay, we're going to do this, do this, do this, do this, do this. And when I started it, I had never done a goniotomy before. That was my very first goniotomy I've ever done. And I've seen it and I thought about it, but I'd never done one. And, when you look at the canal, and let me put it this way, the canal is like this, and you can make your goniotomy here, here, or here. You can make it anywhere along the meshwork, right? Lower, mid, or upper. And I don't know why I did it. But for some reason, I did my goniotomy up top, right at the top of and most anterior point of the trabecular meshwork, right at Schwabia's line. And I don't know, it's just the first one I ever did. And thankfully, I think what happened is when you make it that interior, then you get that shelf that comes down, as opposed to if you make it down here, you don't get that shelf. That gravity won't cause that shelf to come down. So I do think when you are making that goniotomy, if you can make it as interior as possible, having that shelf help. And then when the trabecular meshwork comes down, it can adhere a little bit to the iris and keep it open. And so I think that's key. And so I think Dr. Krishna has asked, the mechanism of IOP lowering with pilocarpine. I think that's the mechanism of it actually, is when the angle opens and if there's a little adherence to the iris, or it just pulls a little bit on that shelf and it causes the pressure to come down and improves the outflow. So yeah, no, it's that is a key thing that I didn't mention, but you astutely brought up, which is the location of the goniotomy site, and it is intentional. The location and the width of it are both with intention.
One more question: if there's a blood in the slums canal, where do you make an incision? You just make over that, or just make on that slums canal?
No, I don't change my incision site if there's blood in the canal. But if I see blood in the canal, I will increase the reverse Trendelenburg of my patient, and I'll reform the eye. I'll inflate it more so that I can minimize how much blood is in the canal. So if I see blood in the canal, I think there's too much episclerovenous pressure. And so I do something to decrease that. So I will, before I start, just do this. And then there was a question about how do you visualize the trabecular meshwork in primary congenital glaucoma. So you do the opposite of what you just asked. So in kids, the angle is so abnormal. I've done this in eyes in Saudi Arabia, which have very advanced types of primary congenital glaucoma. And sometimes you have to just guess because they have no visible structures. But one thing you can do is do the opposite. You lower the pressure in the eye, you lay the kid flat, or maybe even in Trendelenburg, to increase the episclerovenous pressure, to increase blood reflux into the canal. And then sometimes you can see a little bit of blood and then you know where to go. So that you do the opposite in kids if you can't see the angle anatomy.
Okay.
Yeah. Yes, Devendra, you have to unmute. Yeah.
I think it's a wonderful lecture. I think we met, long back in 2014. Since really I'm not doing for 3-4 years. I just saw the Swati, talk to Ganesh sir. Really, I'm scared to do it. But I'm doing since last 2 years, I'm doing the GATT. And really, it helps me whenever I saw your video repeatedly. I saw your lecture repeatedly. I was fortunate to have in that time in your OR, when you are in India, in Pondicherry. So I observed you, then I saw the recording again and again. Really, it's very helpful. So after doing the 2 years, I have certain questions like, in your experience, what are the risk factors when GATT fails?
What's the risk when it fails?
Yes.
Yeah, or risk factors for failing. Is that yeah. We don't know. We really don't know why GATT fails in certain patients. If you look at trabeculectomy and failure after trabeculectomy and the use of 5-FU and mitomycin C and all the evolution of anti-fibrotic and healing after trabeculectomy, it took us probably 30 to 40 to 50 years to understand that. We don't understand wound healing in the canal after this, and that's my next goal. One of my next goals for the next 5 years for me, in 10 years, is to better understand why GATT fails, if there's some inflammatory mediators that cause it to fail, and if there's some things that we can do to prevent that. So no, we don't know why things fail. I know blood reflux and prolonged inflammation can cause that to occur, but outside of that, we don't really know. And I think it's also because, and this is so key, and it's so easy to forget when we're talking about this, is that primary open-angle glaucoma is not the same disease. Right? It's the idiopathic form of glaucoma, meaning we don't understand primary open-angle glaucoma. And when we get smarter about the genotype and the phenotype of things, we're going to be able to further subclassify. Before we understood pseudoexfoliation was primary open-angle glaucoma, right? But now we've subclassified it. Before we understood pigment dispersion syndrome, it was open-angle glaucoma, and now we've subclassified it. So there's probably there are different types of primary open-angle glaucoma where the problem is more in the meshwork. There's probably other categories where the problem is in the canal. There's probably other categories where the problem is the downstream pipe. So we don't have a way of knowing that because we haven't subclassified that type of glaucoma. And until we can subclassify it further, we're not going to be able to explain why some patients do really well and other patients don't.
So my second question, just about your experience, though we have really very good success in some of the advanced glaucomas down the line, 1.5 year, but we don't know in the long run how they behave, how long they will be successful. So I want to learn from your experience. How do you feel it's safe to do in advanced glaucoma? Though there's always some controversy that the IOP spike can cause the further optic nerve head damage. But in my hands, whatever we did, really we don't have the much damage, really works well, but only we have the short duration of follow-up, like 1.5 year. And really it works good in advanced glaucoma also. So want to know your experience.
Yeah, so the advanced glaucoma that I see is different than the advanced glaucoma you see. The advanced usually what I've seen when I've been there, the advanced glaucoma that I see are eyes that, like I mentioned, have been on drops for 20 years. Those patients, they don't do well with GATT. And when I looked at our 2-year data, the advanced glaucoma eyes had a 90% chance of failure, right? And so when the very first GATT patients I did at Aravind, they were all advanced glaucoma. And so I was in my mind, I was like, oh my goodness, they're all going to fail. And then everybody's going to think that GATT is a fake surgery that doesn't work. And I was surprised when I did them that their eyes were different because they hadn't been abused by drops. So they did much better. But that is important because you want to make sure that you don't have a spike that causes them to snuff out. So I think, as you're learning with GATT, I would say save it more for like the moderate to advanced. If they're very advanced patients that you're worried about snuff out, you may want to just go with a trabeculectomy. But the other thing to remember and I apologize, I do need to leave in about 5 minutes. My staff is texting me. People talk about trabeculectomy as it being the perfect surgery, right? If you look at the 5-year outcomes of the TVT study and the primary TVT study, at 5 years, TRABs had about a 60% chance of success, right? 60%. That means 40% of the TRABs failed in the TVT and the PTVT study, right? So we know with glaucoma surgery, everything fails over time, right? And so the people that are critical of this MIG surgery, and they say, well, I'm just going to do a trab because trabs work better in my hands. Well, look at the data. And the data for trabeculectomy at 5 years is not that good. And when you look at the data, because like I said, GATT is a modification of a surgery that's been around for a long time. Trabeculotomy has been around for decades. And if you look at 5-year, 10-year trabeculotomy data, which in theory should probably be better than, worse than GATT, because GATT's less invasive, those success rates, depending on the patients, are about the same. 60 to 70% chance at 3 to 5 years. And so that's what we're seeing also in clinics. So this is a lifelong battle, right? And it's never just surgery A, it's surgery A for a while, and then surgery B, and then surgery C, and then surgery D. So what can we do first that will still maintain options later? Like Dr. Shanta mentioned, what can we do something that can save real estate? So we typically think about saving conjunctival real estate, but it's also, interesting to think about saving trabecular real estate for future surgeries. But it is important for us to look at our data, look at our short-term data, look at our long-term data. But everything I've seen is that these kind of angle surgeries, they work better in eyes that have not been on drops for a significant period of time.
Thank you.
Well, one last question. I think the question on the chat, Davinder. What about oppositional angle closure? Can we do a cataract and a GATT?
Yes, so we're actually just talking about data. We're presenting a poster at the Academy this year, or it might be AGS, actually AGS, on GATT in appositional angle closure glaucoma. And it has to be tied with cataract surgery, obviously. And our paper showed that, I think, without question, cataract surgery is an important component of managing angle closure glaucoma. But it is nice to do something to the angle. And what our paper showed was that you could both do either a goniotomy or a GATT, but the GATT gets better, has better pressure lowering. So I think I think you can win with, when you're doing angle closure glaucoma, I think you can do both, either a goniotomy or a GATT. Sometimes these eyes are so hot and inflamed that it's hard to get a good view. So at that time, if you can just open up a little bit of the angle, either with a hemi-GATT, that might help. But it works tremendously well when it's done in combination with cataract surgery.
On behalf of our president and also TNOA, we sincerely thank for taking your time, Davinder, in giving this presentation. And I'm sure in the future years, you said there is an open OT policy, right? Your operating room is open because we have all come and enjoyed that visit of learning some of the new innovations which you have been doing. And I'm sure there are several other innovations which are coming up. We also chatted something during the last ASCRS about how to identify the suture and things like that. But I'm sure we are all open to some of the ideas from people who are practicing also. Thank you for joining, and we'll continue for a few minutes.
Custom, I request our secretary, Dr. Sriram Gopal, to propose vote of thanks. Dr. Sriram? Yes.
Yes, sir. Good evening, sir. Thank you. Thank you, everybody. It was really wonderful. I won't keep you waiting for long, just a couple of minutes. Really wonderful. Thank you. Thank you, sir, for your wonderful lecture. Me being a retina person, I think I listened to something about glaucoma with utmost interest after maybe a decade even, actually. With utmost interest. And thank you so much for spending your time with us. And as we know that you have to keep going. Thank you. Thank you. Thanks to our dear President, Dr. Ramakrishnan, and the moderator, Dr. Venkatesh, and all the panelists. Thank you, Aurolab, for the sponsorship. Thank you, sir. We won't keep you waiting. Thank you so much.
Excellent.
Thank you, Davinder. Wonderful for spending time with us. Really, we enjoyed. Wonderful.
Yeah, it's my pleasure. You guys be well. Have a good evening, and I can't wait to see you all in person.
Okay, great.
Bye-bye.
Have a nice day.
RK, you want to continue the discussion? We have some of the...
Yeah.
Yes, we will continue.
Yes, Ganesh, any points you want to add on doing what about doing a direct gonioscopy on table? Swati keeps doing that. Now I've seen her to track the suture. Do you have any practice on that? I mean, do you have any thoughts on that?
No, sir, I don't do that. But yeah, it's a nice idea to you track the suture so that you can see 360 degrees, and you could have a good quality, I mean, maybe disposable or even a non-disposable gonio lens which you can ETO and use on the table. I was wondering if anybody in the panel can also tell about the development of PAS after GATT. How would you, what would you feel about it? Is that one of the reasons for failure?
Sir, so I have done around 50 cases so far, and some of the patients are like 3 years down the line and they are off the medication. They do have small pus, but it is not, the angles have not closed completely. There is small tenting, and that too only in the nasal angle, because that is the place where we do the initial goniotomy and the most traction happens in the nasal angle. So that there I'm having it, but otherwise, no, only one patient whom I had shallow anterior chamber while doing GATT, that patient went in for closure, complete. But maybe I didn't identify that patient properly preoperatively, and that patient had already got some narrow angle. So I was not comfortable while doing while doing the surgery itself. And I have written in my notes, shallow chamber. So that patient, yes, that is only one patient which it converted into a full 360-degree pass. But otherwise, all the rest of the patients are doing fine with not significant pass. But I don't know, sir. Sometimes my experience with plain GATT is bad, because plain GATTs have all failed in my hands, but GATT with phaco have all done well. And one of the patients whom Dr. Davinder had also operated while he was here as live surgery, plain GATT was done. That GATT also failed. So somehow plain GATT has poor success rates as compared to GATT with phaco.
Okay. Which do you do first? I mean, the cataract first or the GATT first?
So now I do GATT first and then followed by cataract.
Why not?
Sir, because previously when I was learning, I used to do phaco first and then GATT, but then my anterior chamber stability was compromised and I had to refill my chamber again and again. So that is one reason. And sometimes, because suppose if we have a cataract and we hydrate the wound, then my visibility used to go away. With practice, with time, my phacos have improved. So I don't have so much of fear of getting a stromal edema or hazy cornea after phaco, but still the chamber stability is better when I do GATT first.
Okay.
Can I answer what sir told about that pass? So basically pass, as Davinder told already, actually when we making that incision, the goniotomy incision, most of the cases, if we make the more upper part of the Salams canal, what he told, if our first goniotomy is going to the upper part of the Salams canal, then the chances of pass is much less in compared to when we're doing the midway or inferiorly. So when we're doing inferiorly, the self will not be come down. When we put the incision upper part of the Salams canal, then that the cleavage will be remain open for the most of the cases. Apart from that, in some of the cases, really we see some of the pass, in some cases we see, even do our best also.
Swati, I have a comment about what you said. If
Yes,
you feel that GATT alone versus GATT with phaco, there is a significant difference, it would be worthwhile looking at your data and
Yes, ma'am.
try to look for risk factors and publish it, because we don't have too many comparisons of these two procedures. You have a follow-up of patients with GATT alone or GATT with phaco, but comparing the two, I don't think there's too much of literature.
Madam, we in a case report we recently published, what I found was that patients who present with low vision at presentation, they don't do so well. If you have treated one eye with GATT and then you continue medication in the other eye for a long time, supposing the interval between the two GATT is about 3 years, then the second GATT may not do so well. So the medication use and the very low vision at presentation, these two are important factors which are, I feel, that are a failure for plain GATT. But if the patient is getting operated within a year or two of medication, they do pretty well, provided they have good visual acuity.
Is there low vision because of progressive
glaucoma?
Then
because of glaucoma, yeah.
Yeah.
because of glaucoma. Supposing you present with anything less than 618, that's my cutoff. 612 and worse, I don't do GATT in them.
Again, the plain GATT has, again, there's a high risk of the developing cataract. Some of my case develop the cataract down the line 6 months or 8 months. Actually, we don't, I search for the literature. Again, there's a very few literature who suggested when the patient will have the cataract post GATT, but I have certain few cases who developed NS2 cataract after the 6 months of the plain GATT. So probably like Swati, I also stopped doing plain GATT in my most of the cases. I combined with phacoemulsification.
There have been some case reports of spontaneous hyphemas 2 years down the line, which I think would be really dangerous, especially if a person is doing some driving or anything like that. Have you had any such experience?
madam.
Maybe that's patients who are on blood thinners.
Actually, the trabecular meshwork is still there. I mean, I don't know. We are just opening the leaflets of the meshwork, ma'am. So what I see down the line is the cleft is present in the nasal and superior angle. It gets closed, or the trabecular meshwork is still intact in the inferior. The leaflets get closed somehow. I don't know, the temporal and the inferior angle. So we still have trabecular meshwork. So it's not that we are removing the trabecular meshwork as we do in trabectome or in KDB.
No, I'm not talking about the trabecular meshwork. I'm talking about hyphemas.
Yes, ma'am.
Capillary dilatation, spontaneous hyphemas developing.
Yeah, ma'am, it doesn't happen. I mean,
you haven't had it in your series.
Yes, sir. Krishna, sir.
Yeah, Venkatesh, thank you. Just wanted to share some thoughts about, you're talking about GATT alone or GATT plus phaco. I do not know what conformation changes lens extraction induces after phaco or cataract surgery. What I've observed in open angle glaucoma, advanced glaucomas, where we do non-penetrating surgery instead of trabeculectomy, is that when I have done only non-penetrating surgery, deep spherectomy without cataract surgery, they almost always don't function well after a few months. Many of them have gone in for AGPs. But when I do it with lens extraction, phacoemulsification, even with minimal lens changes, I do now, they seem to work better. So what Swati or who was saying, Davinder was saying, he almost always does GATT plus lens extraction, right? I don't know if they are more successful. We really need to study this. But right now, all my NPDS in advanced glaucomas, if I feel NPDS would be more beneficial, I knock out the lens. Yesterday, we did one with almost a clear lens, almost lens.
Okay.
And I had one question to Swati and Ganesh, sir. What would be alternative if your patient is not tolerant to
be more beneficial?
Pardon me, what? Tolerant to?
If patient is not tolerant. Yes, sir, carry on. Krishna, sir.
Your signal had an issue.
Question, Davinder.
Okay. No.
Hello.
Davinder.
Mute பண்ணிருக்கீங்க.
Unmute to Davinder.
Yeah. What will be your options when the patient is not tolerable to pilocarpine, and certainly be used to prescribe pilocarpine for 15 days or 1 month, depend upon the patient, and reflex, as Davinder told. So suppose some of the patient really they come back within 3 days or 5 days, really they can't tolerate the pilocarpine. So what is your alternative and how do you manage such?
You are giving just once daily, no? Once daily or
twice a day, sir.
No, we have not used pilocarpine after GATT for quite some time now. If we have to use, we ask the patient to wait in the clinic. And if it's intolerant, of course, we cannot use it. We have to use oral glycerol or Diamox to reduce the pressure. But we don't give pilocarpine as a routine for post-operative. In fact, we give only steroids even for only 10 days, 4 times a day for 10 days. Because once you take off the trabecular meshwork, there is no retention of any debris. The whole channel is opened up. So inflammatory debris and all just washes away. So we don't use pilocarpine as such.
I also
If,
don't.
if the patient is intolerant, then of course I'll go for something like Brinolar or something like that. Brinzolamide 3 times a day if I have to use, just to reduce the pressure. Of course, I won't be depending on the constriction of the pupil, but I'll just use something mildly.
Even I use brimonidine, so it works. I also don't give pilocarpine now. So I haven't used.
Coming back to coming back to Shanta Madam's question, that late presentation of hypema, we avoid doing GATT in patients who have hypertensive or patients on cardiac issues. We do NPDS, or now we do canaloplasty. So we leave a suture in the canal and tie it off. So that works well in those situations.
Thank you, Ganesh.
Okay, Sriram.
Ganesh, any questions from the audience?
Repeat GATT, any experience or anything, repeat, you can repeat the GATT.
You can't.
No.
There is nothing to repeat, sir.
Sir, but
We have to only go in for a
GATT,
procedure.
after GATT, whatever filtering procedure you do, whether it is at the limbus or if you put in a tube, you must be very careful that you can have severe hypotony.
Oh.
That is something which we have faced, and you can get quite a severe, even if it,
In failed GATT trabeculectomy?
yes, a trabeculectomy, you can get very low IOPs. You can get 6, 7, 8 and be therefore with hypotony maculopathy for a long time. So you have to be a little careful, make sure that hypotony doesn't occur. Maybe not even use mitomycin C initially, and tight sutures, and do everything very slowly.
And leave some orogel also, sir.
Or leave some orogel also.
Okay.
I think I get some ideas. So only repeat. I think we can certain cases we can do the hemi-GATT, keep the other 180° for the next time if required.
If you are thinking on those lines, you can do a nasal GATT and a temporal GATT and give us a data which one works better.
Previously, we used to do ANT.
No, sir. That's definitely nasal will works well because we see the outer collector channel will be more in the nasal side. But I think some of the people advocate that why you want to calculate the 360? Why don't you save the 180°? Because some of the surgeons say the 180 GATT also works well equally the 360, though the data is not supporting. That's the only.
Is there any comparative study?
No, sir.
180 to 360.
No, sir. No, sir.
Okay.
And sir, it's very difficult. You cannot retrieve the suture at 180°. If it crosses 180, comes at 270, still you can make a new goniotomy and retrieve the suture. But 180°, we cannot retrieve the suture. Then we just have to take it out from where we inserted it.
Yes. Somehow Ahmad is proposing a lot of things about the hemi-GATT. I don't know. I have seen him so many talks. He proposed the 180 hemi-GATT a lot.
I think the GATT is much easier than Phaco. First you get a first GATT done, then you will be motivated to move here. First suture comes out cases will be pulled off. I think much.
Take that question which is on the chat from Dr. Madhavi. He was talking about having a good view, right? One is on intraoperative gonioscopy, the learning curve. But when you want to see the end phase, which Davinder was mentioning, if you're not able to do, you tilt your microscope more or the head more?
I think you tilt both. I think it's
just tilt, you have to tilt both.
Both.
Sometimes I tilt the needle. Sometimes the goniotomy needle, I tilt it up to see the angle much better than I make incision.
Yes, sir.
Okay. So before we finish, Devendra, you have some experience with Tanito, right? So I think Asico makes that, and it looks like another low-cost option, which is available like our Bang and GATT. What is your experience? What is your thoughts?
I think Tanito is a much easier surgery in compared to GATT. It's really basically a Sinski kind of instrument. Once you are master in doing the direct gonioscopy, intraoperative gonioscopy, you can easily perform. I think we have done more than 100 cases of Tanito, and up to the results we are having about 1 year, around 1 year, 2 months, we have results, and most of the patients are doing very good. and IP control is much, much better. Reduce the medicine almost to the 70 to 80% patients are without any medications. So really it has very good outcome up to 1 year. I don't know the future, but up to 1 year, but I used to do the 270 degree, almost not 270 possible in every cases, but around 220 to 240 degree. So I do from the nasal side, then come to the temporal side, do the both side. And really it has really pretty easy surgery in compared to GATT, and it easy to teach also and easy to master also.
For the benefit of audience, where
Dr.
do you-
Venkatesh, I have a doubt.
Yeah.
Actually, more of an innovative query, thanks to your this thing. No, when all this head tilting, microscope tilting, and difficulty in visualizing the angle, from what I learned, the most critical part is visualizing the angle well. So now you have a lot of all these endoscopic devices which they use in DCRs and cannulations, which is there along with illumination. So why can't you just make 3 ports, stick one of the ports with this endoscopic device and use the other 2 ports to go and thread the suture or whatever you're doing inside the thing? You'll have a much better magnified view on screen, through which you can make a nick in the angle structure, thread it and pull it out, instead of doing a direct gonioscopy and looking at it through the gonioscope. You can insert a small endoscopic device through the opposite limbus, which if you take it across the AC and you just let it stay there, it will stay and it will give you a much more magnified and much better image of the, even if your view is not too good, you can still do it.
Yeah, Swati, Gopal is asking about, can you watch a screen and do like your
The heads-up surgery, like the heads-up surgery, right?
but with the
Yeah,
endoscope,
like heads-up surgery.
you don't have to tilt the head.
You don't need much of 3-dimensional this thing in this, because angle structures are flat.
Madam Shanta Madam, you would have experience with the endoscope, isn't it? I think you will see, since you have the endoscope, you must be observing the angle also.
Actually, we have very limited use with the endoscope. We don't use it too much, but I think Dr. Gauri Murthy has described doing goniotomy using the endoscope. And I think there are some publications on using the endoscope, which we use for endo-CPC. They have performed goniotomy. So this is an intriguing suggestion. I don't know how easy it will be.
Because these plastic people have a lot of these newer endoscopes, ma'am, very good ones, which can go through the NLD itself. So NLD and this thing, so which is very, very good. So if they can use it for that, I'm sure we can use it for this as well. Because it's got an inbuilt illumination, it's got a magnification, and you can see it very well on a screen.
Correct, Gopal. I think we have to explore. I'm sure somebody would have tried. I'm sure somebody would have tried. We'll have to even look at literature.
If you look into the net, you get a lot of these ear cleaning devices. It looks like a pen with a small stalk. So it's an illumination, and then you have a USB thing. So that basically it is to stick into your auditory meatus and then clean your ear wax. But I'm sure that it's not thicker than a 20 gauge. I'm sure it's not thicker than a 20 gauge. I've seen one of those. It's not thicker than a 20 gauge. So I think that should work. And that being very small, if you put it through a small port in the limbus and you fill the eye with visco, like what Doctor was saying, there shouldn't be any risk of collapse also, because it's not a very large instrument like your phaco probe. It's going to be a very thin instrument. It's going to be a 20 or a 21 gauge, which is pretty acceptable.
Actually, sir, we want to try it, but again, the work in institute, retina people don't give endoscope. This is the problem.
No, it's from the plastic people.
Yeah, that's it.
Or you can buy one of these ear cleaning devices, because it's made of plastic. You can ETO the device. You can ETO the device and try using it. I agree it's not medical grade, but you can try. You need not try doing the procedure. You can try and seeing how the angles are visualized. If they visualize well, then next time you can try it properly.
Very good idea, sir. We will try.
I will send Venkatesh the link for that thing, which the equipment I'm talking about. It's around 1,000-2,000 rupees on Amazon.
Earbud search பண்ணவொன்னா அது வந்துகிட்டே இருக்கு Facebookல.
Exactly. You got it.
Okay. So closing comments, President.
Yeah, really is a wonderful session. There's no doubt about it. David, the talk was very good, and the panel discussion, of course, when after it left to know people about their own experience, try to listen to the youngsters, Swati, Devendra, Moideen, Ganesh, everybody is doing very well.
You left out Shanta and myself.
Yeah, Shanta,
And Gopal.
We are
First
not
of all,
young
I left
anymore.
out Gopal.
நீங்க பண்ணல நான் பண்ணல Venkatesa பண்ணல இப்போ yeah
Panya
so,
just
yeah we have to accept it na yeah really I think really there is definitely a scope for this surgery because when I saw post-op, I am seeing a lot of post-op nowadays. His eye is so quiet. Eye is so quiet and vision is normal and patient is comfortable. And there is no question of suture analysis, massage, blood needling, and so much, oh my God. A patient has to come so many times. That type of this thing, but of course we don't know about the long-term outcome, but whatever early to moderate glaucoma, but I don't know why we telling this advanced glaucoma, the failure rate is very high. It mentioned.
On anti-glaucoma medications for several years.
But in our case, no, most of the people are coming with advanced glaucoma only.
Yeah.
So,
Yes, yes.
So really, their data and our data will be different actually. If we try in our,
We can do as a primary procedure. We can do as a primary procedure with the cataract. Of course, as Devendra mentioned, no, there is no point in doing just a simple GATT because definitely the cataract will progress very fast. So always, not clear lens with the cataract growth. People, definitely we got to,
Okay.
Thank you all for your wonderful. Thank you, Santa.
Thank you, sir.
Accepting the request. And thank you all. Thank you, Venkatesa.
Thank you, sir. Thank you, sir.
thank you for
Balaji.
giving
Thank you, sir.
Thank you.
Yeah, thank you. Thank you.
Thank you, sir.
Balaji is there.
Balaji,
Balaji, RK sir and Balaji, and I don't know whether Nirmal sir is there. I think few of us need to stay back to just.
Arun வந்தாரு போயிட்டாரு. Yeah.
Thank you.
The
and good night.
TNOA abstracts open it, sir.
Thank you, Manjula. Thank you, Manjula.
Yeah, we opened it today. Abstracts are open.
Yeah. Thank you, sir. Bye, sir.
Thank you. Bye. Bye.
And everybody, please fill in that one form which you sent, Google form which you sent through WhatsApp.
Okay, sir.
Okay, sir. Okay.
Mm.
Okay, thank you.
Thank you. என்ன சிரம் என்ன யாரும் வர்றாங்களா?
Sir, அதான் பார்க்கிறேன். யார் பாலாஜி, பிரசன்னா.
பாலாஜி.